took over the directorship of the Southwest PADRA, and so has those typically have the opportunity, and she states here in the bio that it is part of training, new physicians in Parkinson's, and will have the opportunity to work across all disciplines in a multidisciplinary way in teams to really kind of coordinate the best care for people with Parkinson's, and as well as like sharing that information not only across all the whole VA healthcare system, but with medical school trainees and in the general public. So today we'd like to welcome her in talking about the gaps in care and management of women with Parkinson's disease. Please welcome.
Thanks so much. So it's really an honor to come out here, and it did take a while. I flew into Chicago, and my little one is there. We drove out here this morning, 3 hours, to come see you all. And I could have done this over Zoom, honestly, or some other mechanism, but I really love coming out into the community to see faces like you, and especially women who get together and share their stories and share what it's like to live as women living with Parkinson's, because it's not something that most people hear about. And so, so maybe we could take a minute just to look around and at each other's faces, because I also, one of my interests is actually on loneliness and social connection. And we were sort of disconnected, right, during the pandemic. And a lot of us were only on Zoom, and I ended up hosting a virtual support group for Parkinson's patients at that time. I interviewed over 120 thought leaders over 2 years to try to connect the worldwide community of people living with Parkinson's, caregivers included, and we started talking about things that were really unmet needs. And so I had in those thought leaders a number of patient voices and a number of very strong women voices who were advocating, and I have really become passionate about talking about their stories, because this is something that we really don't do very well. We don't do research in women living with Parkinson's, so most of the therapies that we have are really centered around men. So maybe we can take a minute and just, as a show of hands, who are women living with Parkinson's in the room? Amazing. And I think it's lovely to get out and see each other's faces, because often if you go to a real usual support group, most of what we talk about is really men who are living with Parkinson's and their wives who take care of them, right? So I think it's a very different story when we have women coming together and talking about their sort of issues. So I'm just going to go ahead. Unfortunately, we had a glitch with the slides, but I'm going to use my slides to kind of remind me about what I wanted to say. So classically, when we talk about Parkinson's disease, we use these images, and I had and you'll get the copies of my slides, and you're welcome to take a look. And if you have any questions, you can kind of reach out to the organizers and stuff. But we talk largely about Parkinson's as a male dominated disease. All the pictures, if you think about it, you close your eyes and think about when you were, 25 or 50 even, what were the images that you thought about with Parkinson's disease? It was really an older white man, right? It didn't look like you, and it didn't look like me. And there are people on this planet that look like me that are getting their diagnosis delayed because we teach medical students these images of young and old men. Michael J. Fox is an image, but largely older white men. And I think the whole thoughts of what President Biden and sort of that sort of picture of an older white man who may be cognitively declining and slowing down, a motor disease. These are the images that we really have talked about. And so when people come in and they're anxious, they have depression, they have changes in their sense of smell and constipation, and also sometimes present with the classic symptoms of tremor, stiffness, and slowness that are women, younger women, especially women of color. People don't realize that we can get this disease, and it can look very different than in men. So that's important, that we change the sort of image, and we're trying to do that, one medical student at a time, thinking about how to rebrand really this disease with the images. So I am a movement disorder specialist. I did 2 years of training in movement disorders, but many of you living with Parkinson's know that it's not the motor symptoms often that bother you the most. It's really the non-motor issues. So things like anxiety, depression, apathy, sleep disorders, constipation, changes in your urinary function, even changes in your sexual function. These are all things that can really bother you that we don't really talk about. a lot of our studies are done around looking at outcomes like speed of gait or things like reduction in tremor, and really the things that bother our patients the most, which are really this non-motor cascade, are largely left untalked about. And really there's a huge mental health burden, as I mentioned. A lot of patients, 40% of our patients are dealing with depression and anxiety and things like that. And often healthcare providers don't even know that this is part of the disease. So it's something that we really need to help people to understand that really can make a difference. I also wanted to take a minute to talk about the word stigma. This is something that a lot of people don't really realize, but there is sort of a sense in society that anyone who is different than what the mainstream things that sell products are different than everybody else in society. And that can include sometimes women, sometimes people who are older, so ageism, there's an ageism in our society, and anyone that gets sick can really feel sort of different than everyone else. And I think when you're a woman living with Parkinson's, stigma is huge. There's a stigma that you put on yourself as someone who has maybe motor disability, sometimes who may be embarrassed by tremor or dyskinesias, things like that. And so what happens with stigma is that there's a sense that the community thinks differently about you, and then there's also a sense that you think that the community thinks differently about you. And that's sort of self-stigma, the sense that other people are looking at you as somebody who looks different, is acting different, and then you isolate because of it, because you don't see other people that look like you. This can be very troubling for our people living with Parkinson's, especially women who don't see other women living with this disease often feel very isolated and alone. And the normal reaction to that feeling is that one isolates further. And one of the things that I've really grown to be really interested in is the importance of how impactful loneliness is in our health. And loneliness can be very impactful in people living with Parkinson's. We have research showing that it's as bad for you to be lonely as the beneficial effects of exercising 7 days a week for 30 minutes a day is good for you. So when you think about it, you know, we all think that exercise is medicine, but we don't realize that social connection is actually part of the medicine too. So I think that that's really important. If there's one thing that you take away from this talk, it's to sort of recognize the impacts of possibly of stigma for you and how that may impact how you connect with other people that you love, and to try to really work hard to stay connected. And the people that are in this room are already drinking the Kool-Aid, right? You made it out to this talk. But there are people that you may know and love that are isolated and aren't coming out to talks like this. They aren't making that trip across the city. So think about those people and try to reach out to those people as well. And it's not even just people living with Parkinson's. It can be people who are older, people who are sick with something else, you know, many people who just feel like they're isolated and kind of stuck. So those are some important things. So wanted to spend a minute talking about the concept of wellness. So I am a Parkinson's doctor, but I'm a neurologist and I'm trained in movement disorders, but I also have a strong background in what we call wellness. So wellness is sort of the concept that a person can choose lifestyle choices every day to help them live better. And so the sense that you can be proactive in finding things that can help you. And so in the standard Western healthcare system, as it is practiced now, many of you may go to a neurologist, and some of your neurologists actually knew that I was coming into town and sent me kind messages about trying to teach you some of this stuff and had wished me well. I know you have some great doctors out here. But the healthcare system is such that we have often more and more patients to see with less and less time. So often we're seeing patients for maybe 15 minutes for a follow-up, maybe 30 minutes for a new patient. I'm lucky because I work at the VA. Sometimes I get 30 minutes to spend with my patients as a follow-up and 60 minutes for a new, but that's still not enough to cover the host of things that are troubling you, right, in terms of your quality of life. And it's important to realize that there are things, and not just pills and surgeries, but there are things that you can do every day in your own lives to help you feel better. And for women, that often looks quite different than what might be available or acceptable or exciting than for men. So I want you to think about, are there things that you love to do that bring you joy as women that we can kind of start to drizzle in more of? One of the problems that we realize for women is that we don't take, and I'm going to include myself in this, as mothers, as grandmothers, as wives, as daughters, we don't take time to care for ourselves because so much of our identity is spent in taking care of other people. So because of that need to be caregivers, we tend to sometimes diminish our own needs. And I want to tell you that to live well with Parkinson's disease, your own needs and your own health is actually really important, and what you invest in yourself every day. So be that exercise, be that getting a good night's sleep, be that getting nourishing food, be that hydrating well, be that socially connecting, which is something that we haven't really talked about a lot in medicine. Those are all things that are important. And then we have another category that I want to spend a minute talking to you about. So I actually have a background in yoga and mindfulness teaching. I've been really interested in this because I actually find it very helpful for myself. But I think that it's actually a very important area, the mind-body sort of world of practices for people living with Parkinson's is actually really important. So time to shut off your devices or shut off the TV, find time to be kind of quiet, to be able to spend time with yourself, be that in prayer, if that's available to you, even in your church or synagogue or wherever you go. Be that in nature. It's a beautiful, summer day, going for walks in nature, finding stillness and these sort of things, or meditation, yoga, things like that, Tai Chi, or even in arts and music. So when you get into the flow state, if there's things that you really love that bring you joy, I have these conversations with my veterans and I'm like, what brings you joy? And the sad thing is that we don't talk about this very much in medicine, right? So they don't come to me with prepared answers, and it takes a while for people to remember what they really love to do. So I don't know what you guys like to do in your community, but if it's dancing or bowling or gardening or these sorts of things, we really want to be intentional about creating that kind of environment for you every day if you can. So when we talk about things that people with Parkinson's want, there's been some papers written about things that people with Parkinson's want, and one of my heroes in the sort of thought leader space, who is a woman herself living with Parkinson's, is actually Sonia Mathur. I don't know if any of you have read her books or anything, but she's a really amazing woman. She's actually a doctor living in Canada, and she's Indian. She went to medical school a few years before me, and she wrote a paper about what people with Parkinson's really want. And the things that we've been told that people with Parkinson's want are quite different than what we actually give you as your doctors. So people with Parkinson's actually want guidance on things like the sort of lifestyle choices that I mentioned. They also want to be able to find support for themselves and their family. They want to be able to get good information about what to do to live better with Parkinson's every day from vetted resources. I think the internet is broad and there's a lot of information out there. So ways to find vetted resources are also very important. So this is sort of just the background of things. And I think that we really want to be able to care not just to those images of the older white men, but to just who we see in front of us. So be that a woman, be that somebody who's a young woman living with Parkinson's, be that somebody who may be a person of color with specific religious beliefs, with certain language issues that are barriers to getting standard care. So really, I think the time has come, and I think many of us as physicians feel that we have not served everyone living with Parkinson's well. And when you look at studies across the board, most of the studies that we have are almost 98% Caucasian, and most are actually men. So we really need to get you as women coming out to talk about what your needs are, and also to participate in research so that your voices can be heard and that we can really cater the therapies to all of you. And it wasn't until actually relatively recently that we required drug companies and other companies to report how many men and women were involved in the study. It was actually only in the last 20 years that that's been required. And when you look at animal studies, actually, the male animals are the ones that research is being done on. The female rats and mice and things like that are actually taken out of these sort of studies because it's messy to have rats that get pregnant or rats that have their periods or rats that have hormonal changes. So we actually have such a huge bias that I didn't even realize until I really started looking into this as to who is getting care and who isn't. So we wrote this paper, and I'll just show you. Actually, I'm going to pick up my laptop for a second because maybe you can see these faces. here's some faces, I don't know if everyone can see, of beautiful women living with Parkinson's. And so the paper that we wrote, which is entitled Unmet Needs of Women Living with Parkinson's Disease, Gaps and Controversies, and I'll send this paper to you guys so you can take a look. There's some very cool images that we were able to put. And so the reason I showed you that picture of who my co-authors were is because the paper was written with 3 medical providers themselves. So one is a dietitian living in Ireland. Her name is Rochelle Flanagan. Sonia Mathur, who I mentioned, is a family doc. And then there's a woman who's actually an OBGYN who's younger, and she's in the Netherlands, and her name is Annelien Oosterbaan. And so the 3 of them gave us ideas, and we really wrote the paper together. And the last author is actually Elena Moro, who's in Italy. So it was a very global representation of really what the gaps were in taking care of women living with Parkinson's. And so we wrote this paper together. And so some bottom line important things to understand is that we don't fully understand why, but women, especially in the North America and in the Americas, seem to get Parkinson's disease less often than men. So it's about 2/3 men and 1/3 women in the US, for example. But in Asia, that ratio is actually equal. So women and men get it the same in Asia. So we're not sure why that is, but that is something, and just because women get it less often does not mean that they shouldn't be represented. It's not like it's so rare, right? 1/3 women is actually a lot. And when you think about how long women live, right, women have longevity, we're actually taking care of a lot of women quite well into, sort of late ages. So it's really important that we care about this and that we do it well. In my experience, we haven't done this well and we have a lot of work to do. So women tend to get more mood stuff with Parkinson's. So they tend to have more depression, more anxiety, higher pain scores, sometimes more fatigue scores. They also seem to have more of a tremor dominant type of Parkinson's. Many women who are younger, who are still getting their periods, will say the week before they get the period that their symptoms get worse. So there does seem to be some hormonal influence as well of symptoms and how they vary. Also, women who are going into the perimenopausal time frame say that their symptoms get worse as they're going into that perimenopausal time frame, and after menopause, things tend to even out. And for many years, I had patients who came in and asked me, "Doc, is this, this or that part of my menopause or part of my Parkinson's?" And now that I'm actually going through menopause myself, I realize how confusing it is. So I really have a new understanding of, all of the things that women go through throughout all of these sort of time frames. One of the things that we didn't quite understand is how safe it is to get pregnant on medication for women. Believe it or not, there are women that are, for example, Sonia was 29 when she got diagnosed with Parkinson's, and she ended up having 3 pregnancies with 3 beautiful children with the diagnosis of Parkinson's disease. And so 2 of those children are actually interested in medical school, and we collaborate with one of them. So one of them's actually in med school now. So it's pretty amazing that she's sort of continues to kind of give back in so many different ways. Women are also tend to have a tendency to lower body weight, right? We are already tinier, and then we have a tendency to lose weight quicker when there is weight loss in Parkinson's, and get dyskinetic more frequently. So we really have to be mindful. There's some sense that, being too heavy is a bad thing, but in Parkinson's, if you start to lose weight and get too lean, we really start to worry about a number of things. So we really want to keep people eating well, keep people concentrating on keeping their bone mass and their muscle mass up. Because as you lose muscle mass and bone mass, you become much more at risk for breaking bones and having bad outcomes in general. So being, keeping those up is really, really key. So hopefully people are getting their bone scans done yearly. Checking their vitamin D levels is suggested, and things like that. And for women, it's certainly important to make sure that we're checking in with the doctor. If we start to lose weight, we need to get in and get our medications adjusted, because what can happen is there can be a little bit of like this vicious cycle the weight gets lower, the amount of weight in which the same pills are distributed starts to go down, and so we end up having more sort of, the body feels like it's on more medicine and then gets more sort of extra movement happening, and then more weight is lost from that extra movement. And so we can have this sort of vicious cycle. So really keep that in mind. One of the other things that women tend to have is we are not as interested in deep brain surgery for whatever reason. If you look at deep brain surgeries across the country and across the world, most deep brain surgeries are done in men. And we realize that when we look at the women that do get surgery, that they actually do very well. So for whatever reason, we tend to have less interest in offering deep brain surgeries and advanced therapies to women, but women do very well. But even when we do offer these surgeries to women, for whatever reason, and we're still trying to understand that, they tend to not want these surgeries. And I'm not too sure why. We have to kind of understand that. Maybe it's the way that we're describing the risks and benefits, or maybe they just don't want to have hardware implanted in their bodies. But these are some things that are important areas that we have to improve. So in thinking about really how to do better, one of the things that's really important to realize is that many women, and I don't know maybe if women would be willing to share in this room, how long did it take you to get the right diagnosis? Because when we talk about this with other people living with Parkinson's, men tend to be diagnosed sort of quicker. If they have symptoms and they go complain to a doctor, it's often pretty quick that they get referred to a neurologist. And then if they do need to see a movement disorder doc, it's pretty quick to see a movement doc. Women tend to have a delay. Often they're told maybe that there's something maybe that they're anxious with, that's all in their head. Is this a common experience for you guys in the room? Yes?
8 years for me.
8 years? 8 years.
I was misdiagnosed with an essential tremor.
Yeah, so that's,
The first neurologist I saw asked me if I was shaking my leg on purpose.
okay.
My GP sent me, I said I had my arm was kind of numb. He sent me right away, he said, "You ever hear from Parkinson's?" He sent me right to the neurologist.
Okay, good.
So I was one of the lucky.
You were one of the lucky ones. Anyone else have something to share about that? Did you get diagnosed quickly or did it take a while? Yes?
My daughter-in-law, good friend is a neurologist.
Oh, okay.
Practice here.
Okay.
I got in to them quickly.
Okay, that's good. It sounds like you had the back door.
In the clinical, and I got this other joker.
You had another joker in clinic? Okay. Lady in purple.
I just want to say I had first visit to my doctor. I was diagnosed.
Okay, okay.
I kept asking about Parkinson's, and they said, "Oh, you don't have Parkinson's." Women your age, I was like 36.
Yeah.
When I started having symptoms.
Yeah,
Women your age don't have Parkinson's.
yeah.
I know one of our board members who isn't here today, I think it took her like 12 years.
12 years. Yeah. Yeah, yeah. And it's even worse for women of color, actually. They're told that it's all in their head or that they're making it up for a long time as well. So, and then when they finally get diagnosed, then they don't really trust the system, right? Because it's like something that has not served them well. So I think, we just have to be open-minded and certainly, be understanding of many of these sorts of things. So interestingly, women tend to see neurologists less with Parkinson's. They're not offered a neurology visit or they don't get follow-ups as much. And whether that's that they may not be able to travel or other things, I don't know. But, and we know that seeing a neurologist is a good thing. And seeing a movement disorder neurologist, if you have an available one, even once a year is a good thing. Neurologists tend to help their people living with Parkinson's to get more rehab type therapies. They refer for more rehab therapies like physical therapy, occupational therapy, and speech therapy. They tend to keep people out of skilled nursing facilities more if they're taking care of people. People with neurologists in their mix have lower risk of hip fracture, lower risk of hospitalization, and lower adjusted likelihood of death. So seeing a neurologist is a good thing. So really try to push for that if you don't have access to one. It's really important. And we just see, there's a slide that is in the deck that shows this classic delay in care, but it's, can be years that women are delayed in care and then don't get the follow-ups that they need as well. So, so women with Parkinson's are less likely to visit a physician, more likely to be placed in a skilled nursing facility, and really often are more likely to have to pay a caregiver to take care of them than men. And so again, I think, getting back to this caregiver role, I know it's a bit of a personal question, but I think a lot of people that I've taken care of, when we talk about, what are their main fears, what do they really want to be, what is the one activity that they want to try to preserve, in their lives, and it's often around either being able to spend time with their kids or their grandkids, and play, like literally play with their grandkids. And I know I've had women cover up their diagnosis just to be allowed to hold the grandbaby or to play with their grandkids alone. They've literally like covered up the diagnosis to their families, which is very stressful. So I think we have to be honest about, how stressful some of these things can and how impactful it can be to not be able to be a caregiver for yourself, for the people that you love. But I think also to really emphasize that taking care of yourself is important. And I think we as women often are raised to not give ourselves love. And it's actually people get very guilty. Like, I'm like, well, why don't you just say no to that? You don't want to do that. You don't have to do it. And they're like, no, I have to know. Okay, well, so, I think saying no, learning to say, I need an hour of time to do this for myself, or even, getting your nails done or getting a massage or, having a glass of wine with your best friend. Is really so key. So I think, we just really need to give ourselves the love that we give to everyone else. And we see that time and time again with all the studies that we are doing. So, so there's a quote that we have here. Although I realize that getting this disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. So I think, there's a sort of shame and blame and guilt. And Sonia Mathur actually wrote a paper about that as well with a few other women talking about this. So, so I think it's just really important. The other thing is that women with Parkinson's tend to be less likely to be accompanied to office visits. They come alone, and sometimes even are more likely to live alone with this disease as well. So I think we really have to do something to change this. So there's an image that I'm going to show you that's a bit different that we made, and I'll just hold it up. So this is the image that we created. One of the only images that has looked like this of women that are, two women that are, when we list the symptoms here, so you'll get these slides, but in a PowerPoint if you'd like, and this is in the paper, but these are two women, and we list sort of some of the symptoms that look a bit different in women than men. And so, so I think that's sort of a great sort of image that has rebranded Parkinson's, and hopefully we can continue. We're trying to teach students around these new images. The first image of my talk is the classic images of the Hone and Yar stages that are all of Caucasian men, unfortunately, and that's what I learned about Parkinson's from, is those sorts of images. So women, I'll just read these symptoms that are a bit different. So women tend to have more tremor-dominant Parkinson's, more dyskinesias, and sometimes more restless leg syndrome. They have a slower disease progression, though. Non-motor symptoms in women are mood and sleep disturbances, anxiety and depression, fatigue and apathy, pain, and urogenital symptoms are more common in women. But women have less cognitive impairment and things like that. And then psychosocial issues, women talk about more psychological distress, more issues with negative and destructive self-image, loss of femininity, impaired sexual intimacy, feeling of not being heard, and there's also a sense that they downplay symptoms as well. So women often don't want to bother their doctors with their symptoms, so they tend to downplay them, right? So I think it's just so important that we really think about that. And women are grossly underrepresented in Parkinson's disease trials. So I think we came up with 15 things that women should know about Parkinson's that we will share with you, and there's also a blog that I wrote and some other things. So I will just quickly go through them. Okay, so you can get Parkinson's disease. Women can absolutely get Parkinson's, and knowledge is power. So it's important to get education. I list some vetted resources, so things like the Parkinson Foundation, the Fox Foundation, Davis Finney Foundation. I have a blog that I write with Mike Oken, who's a thought leader in our field as well. Parkinson's disease has non-motor manifestations that can affect your quality of life, including bladder and pelvic floor issues, constipation, sexual dysfunction. It also has a host of mental health manifestations that can hugely impact your quality of life. Things like anxiety, depression, apathy, sleep dysfunction. The hormonal cycle can affect your symptoms quite dramatically. Some women report worsening of their Parkinson's symptoms around menses or as they go through menopause. So then the next are about seek out subspecialized and personalized care. So get the help you need from experts. Seeing a Parkinson's disease neurologist at certain time points is helpful, as well as getting followed by a neurologist. And make sure that you prepare well for your appointments and take an advocate. Write down your main complaints, bring in your pill bottles, write down what refills you need, have your other providers' names handy, bring in an advocate to be an extra pair of eyes and ears, and have them take notes for you. Read the after visit summary paperwork, so you usually get a printout. Read that as soon as you leave and make sure that you understand the plan. Find a provider with whom you have a good rapport. You should feel seen and heard. You should feel that you should be open about your symptoms and your questions, or you can be open about your symptoms and questions. You should feel that you can trust them. The doctor-patient relationship is a sacred one. Even if you have to drive 2 hours to find a doctor that you can check in once a year that you really love and gets you, I would make that time because it's important for you. And then engage other providers, physical therapists, occupational therapists, speech therapists, yoga teachers, personal trainers, dietitians, psychologists, social workers, even spiritual leaders can be part of your team. Make yourself a priority. These are the next two. So take care of yourself. You are very important and no less important than anyone else in your life. It is hard for people, especially women, to take the time to get what they need and give themselves love and nourishment. You need to take care of yourself before you take care of anyone else in your life. That's that oxygen mask analogy, right? Put your oxygen mask on first so that you can take care of other people. And I have so many women that come in and everybody in their family wants them to take care of themselves, and they're too busy worrying about everything else that they have no control over than to take care of their own stuff. So everyone's worrying about everybody else, and it's really not very helpful. So, and then I get to worry about everybody. So it's really, I need people just to take care of what they have control over. Wellness is important. Find proactive things that you can do for yourself every day to make yourself feel better. Think about incorporating exercise, mind-body strategies like yoga or mindfulness. What do you like to do? What brings you joy and meaning? Find ways to increase them in your life. Realize that sleep, hydration, healthy diet can make you feel better. Bone health is also important. Find your tribe. You will definitely do better if you have an advocate, and this may be someone other than your spouse. Think about who supports you and who you can engage as part of your advocacy team. Who is your biggest cheerleader in your life? It may be your sister, your best friend. Bring them to your appointments and include them in how you are feeling. Ask them to help you document your symptoms so you can communicate with your providers. You will do better if you have a tribe. Social connection in Parkinson's disease is huge. Having a group of friends who you feel connected to outside your home is important. Planning social activities with people is important. Laughing, playing, relaxing, sharing your stories with others is tremendously beneficial. Joining a support group can be helpful, especially a support group with other people just like you. The unique sort of needs of people can be very helpful. For women, there are a few national support groups even, some that are fully online, and I've listed a couple here, including one of my patients runs Twitchy Women, which is Twitchy Woman, which is her own organization. And then get involved. So advocacy is so important. Advocacy and research can be very empowering if you participate in them and can give women with Parkinson's a tremendous sense of purpose. Your voice is important and representation matters. As I mentioned, most trials to date involve everyone but women. So the focus needs to change. So I also included a couple slides. So Annalyn wrote a book that is downloadable. It's yopdwomen.com, and that's in the slide deck. She's also, one of the needs that we came up with was needing to have a registry for pregnant women to register to say, I have Parkinson's, I'm on this medicine, so we can follow every other medicine and every other disease state has a registry. And she started one out of the Netherlands because she was actually pregnant when she found out about the Parkinson's. So some of these changes are small, but they're starting to happen. There's a new app called My Moves Matter that Rochelle Flanagan, as I mentioned, has been creating. I don't know if it's in real time yet, but it's something that is an app that you can use on your phone that tracks your menstrual cycle, tracks menopausal symptoms and things like that, along with Parkinson's symptoms. So these are things that came out of our paper that are already starting to happen. There's a book called Being Well with Chronic Illness by Kat Hill and Nancy Pete. Kat Hill is a lovely patient living with Parkinson's who I think is a midwife, and I've given some talks with her. This is also in the slide deck. So I've given you some resources, Twitchy Woman, and a few other women's women's Parkinson's projects, things like that. So there's a number of organizations that you can join worldwide. So just really quickly thinking about sort of how to be the agent of your own change. So what people have realized in healthcare is that just showing up and having me as a doctor give you a pill every 6 months ain't gonna cut it. It just ain't, right? It's really so important to own your own disease and to realize that denial is not a good thing. So we really need to think about understanding that this disease is something that I'm going to live with. It's not going to define me, but there are things that I need to do every day to live better. When you do that, there's a change that happens, and really that shift is so empowering, actually. And so the types of things that can really worsen quality of life in Parkinson's include things like stigma, loneliness, demoralization, just from the diagnosis and things like that. Things that can improve quality of life include things like self-efficacy. So that's really when you feel like your own sort of agent of your own destiny. Resilience, so being able to pivot, as I did today. Social support. Psychological flexibility, so being agile and sort of not being focused on having to have control over everything, right? As human beings, part of our nature is to need control of what am I going to look like in 10 years? Am I going to be doing this in 5 years? What am I going to feel like in 2 hours, right? And Parkinson's takes that away from us. So I think the ability to sort of let go and to really stay in the moment, not worry too much about the past, not worry too much about the future, but just enjoying the moment. And that's a lot about what mindfulness is like, or being with each other in truly with each other in conversation, talking about your own issues and understanding other people's issues and really supporting each other. That's really what that's about. And empowerment and education is huge. And so coming here together today to learn something is part of that whole story. So there are other things that we really sort of think about. And there's this concept that I just want to spend a minute talking to you about called social prescribing. So in the pandemic, we realized how important social connection was. And there's this sense that, and this is a concept that has been known about in the UK with the National Health System, that we as doctors can literally prescribe social connection as I may prescribe a pill to you. And we can refer to people like support group leaders to help connect you to things in your community that can kind of help to sort of support you. And some of the interesting research that I didn't realize until I started looking into this is that each of us needs connection in 3 spheres. So one sphere is the intimate sphere of connection, where we have somebody in our home that knows us well, that takes care of us, perhaps your husband or wife. Then there's this relational sphere where we need a friend circle outside of our home, maybe 3 or 4 friends that we're able to confide in. And then there's a societal kind of connection in which we have a connection to something that brings us meaning and purpose, and we can share that with people in our community. So for some of you, it might be a religious group. For some of you, it might be, Saving the Whales or whatever group, or I'm not sure what's the group in Indiana. But there's a number of things that may bring you meaning and purpose. And so getting connected to that, maybe a Parkinson's support group, a veterans group. So really thinking about those 3 spheres and being intentional about doing that. So we really want to be trying to do this more and educating people more. And I'll just leave you with this last sort of circle, this last flower that I'll just share with you. So this is an image that we created, and I don't know if you can see it, But basically, we have musical interlude while I'm showing you. So this is the last image.
I know whose phone that is.
This is the last image here, okay? And this is the image of the wellness sort of circles that are redefined a little bit. And basically we have the patient in the middle. I'll just describe it to you. The patient is in the middle, and then we have a number on the petals of things that you can do in this wellness sort of world. So sleep, exercise, diet, finding meaning and purpose, social connection, some intellectual engagement, mind-body approaches, and then optimizing your general medical health as well. So what we realize is that so much of what we talk about in the Parkinson's world is just tremor, right? We don't even talk about the non-motor or the mental health stuff, but you also have the rest of your body that you're living in, right? So it's so important that you take care of these aspects of your general health too. So bone health, gut health is so key. Things like your dental health. Because if you have really bad dental health, it actually puts you at an increased risk of things. Hearing and vision are huge. So if people are losing their hearing, they're at much higher risk of having cognitive issues, and same with vision. So all of these things are important too. So those are the things, the petals on the circle, and then we have some sort of other leaves and petals underneath that are really the people that can help get you all of these things. So things like physical therapist, a dietitian or nutritionist, your general doctor to look at the sort of vision and hearing and things like that, mindfulness teachers, yoga teachers, occupational therapists. But then we have, a petal at the bottom or two looking at people that might be a psychologist or faith-based resources, support groups and community. And really, I think so much of what we do in medicine is largely in my office in a white coat with me sitting here and you at the other side of the desk. But I want you to really envision or re-envision healthcare as really coming back to your grassroots of where you live in your community and you and each other as part of the healthcare paradigm. Because, if we're relying on our crazy healthcare system, which is ever more insanely broken, in my opinion, then we're really in trouble. But I think, what we have to really realize is that the communities in which we live in, with this beautiful, sort of community that you guys all share here that I'm able to sort of peek into for, today, is really where so much of our lives are lived and where we can really kind of lean on each other and get and give love to each other. And I think that's fundamentally what has really been forgotten, I think, in so many of our paradigms. So I congratulate you for coming out and seeing each other, and I hope that you spend some time at the lunch hour actually exchanging phone numbers and maybe making a little girls club of women that could go do some fun stuff and, get some, I don't know what, massages going on or nails done or something, some fun stuff, right, for women to connect. So I really, hope that you will do that since you've taken the time to come out here. And I'm sorry my slides didn't work, but hopefully you got some of the message and you'll look at the slides later. I can repeat it if you want. So this is attached.
I get healthcare at the VA, and they do not normally check hormones. And I think it should be done, and I think they'll do it if I ask for it. But what exactly should I ask for as far as checking hormones?
Yeah, so I think right now we don't have a sense for the female hormones of what that means, and we don't have any data to support things like hormone replacement therapy. I think what would be reasonable is to check thyroid function once a year, probably B12 level, checking your vitamin D level, those are reasonable. I think those are the main ones, and just checking maybe like a blood panel, a CBC, and liver function, things like that. So. But at the moment, we don't have any labs that we check for the female hormones. But it is helpful, I think, to at least if you have a sense, if things are changing as in a hormonal state. So let's say, for younger women, if they're menstruating and they have a change the week before, sometimes they need an extra dose or something here and there because they're not feeling so hot. Discussing these sorts of things with your doctor is helpful so that they're aware. And then in the perimenopausal period, I think some women have felt changes going into menopause, within the menopausal time, and even a year or two after. So, just talking to your doctor about that and helping them to understand that these things do matter. I'll send you our paper so you can show them as well that there's now a paper out looking at these sorts of things. So, any other questions? Yep. Leading green.
Not a question, but
Okay, sure.
I wanted to ask you if you knew about the PD Pro app.
The PD Pro app? Is it the Pro PD app?
Yes.
Yes. Okay. Yes. Lori Mishley's app.
Yes,
Yes. Yeah. So the loneliness work comes from work with her. She and I are close colleagues, and I think it's great. I think being able to monitor your own symptoms is helpful, and I am aware of it.
I'd encourage everybody to really
Yeah.
look that up. I've used it for about a year,
Okay.
and it's nice to see how you're tracking.
Yep.
And what it is it's just an app that has questions that they ask you to rate your, like, have you fallen? How many times have you fallen? Like, constipation, would you say it's on a scale of 1 to 5 or 1 to 10?
Mhm.
So through those questions you get, and it gives you a graph every time you use it.
Yeah.
You can do it monthly or quarterly or once a year.
So she's talking about this Pro PD app, and it's run by a Dr. Lori Mishley, who's a naturopath up at Bastyr in Washington State. And she and I have done research on, things that are modifiable. So what we're trying to look for are things that one can modify in your daily life, perhaps diet or exercise or, different things. And she has a way to sort of self-report your symptoms, and you can kind of track it for yourself, and also it feeds back into a database that she's collecting information on. So, I think I don't know, it's free? Is that right? Yep. Yeah, it's free. So, yeah, you can check that out.
Is it geared toward Parkinson's? Or
Yes.
it's more generic?
No, it's a Parkinson's app. Yeah. So.
I'm dyslexic. Pro-PD.
Pro PD. Yeah.
Yeah.
Yeah. Okay. Any other questions?
So you said it goes to a database?
Yeah, so Lori Mishley is collecting data. And actually, interestingly, on that database, so we were talking about how women don't participate in research very often. What we've noticed is that these sort of survey-based things that are especially electronic surveys, women are actually well represented in her database. So I think women like to do things in the comfort of their own homes, and find time kind of where it suits them, where a lot of other research studies end up being something you need to drive in for multiple times a month, or over a year or two, having to go in multiple times to the center. And I think it's often very hard for many people, including women, who may not have someone to drive them in to participate in these studies. So I think we are, as a community of physicians and researchers, trying to find ways to engage women and people in rural places and people who may not have access to paying for $20 to park in a big hospital in a metropolitan area, ways to help your average person and that we want to be serving better, to be able to gather data from them. So I think these sort of surveys, I think the Fox Foundation has a survey that they do. I mean, there's a number of surveys, and there's actually one specifically for women on the Fox Foundation website, so you can kind of check it out. So I think, yes, that was the My Moves Matter. That's by Rochelle Flanagan, and yeah. So there are a number of folks that are sort of by women, for women kind of stuff that's happening, which is probably the way that it has to be in some ways. So, any other questions? Yep.
I know there's always talk of the cause of Parkinson's, and I know particularly the environmental risk factors and all this stuff. There's all the talk of paraquat, particularly even I've encountered when I worked at the VA a few women who served in Vietnam with exposure to now in later life, have developed Parkinson's too. Do you have any comment about that? And a second question is, there's a movement among some of the Parkinsonians in Indiana who want to continue to have the state create a Parkinson's register. What are your feelings about
Sure.
Do they have that in California?
Yes. Okay, sure.
What are your feelings about that?
Okay, so I'll repeat those questions. So one was about environmental contributions and what my sense of the environmental contributors to Parkinson's are, be it Agent Orange and things like that. And then the second question I'll mention in a minute. So I think that we don't know what the cause of Parkinson's is, even after all of this research. We have a sense that there is some genetic predisposition. There are some genes that people carry that predispose them, and there are some studies that you can get involved in. For example, PD generation is a study that is run by the Parkinson Foundation, where they can mail you, I think, a kit, and you can, I think, spit in a cup and send it to them. So these are some gene studies. And even if you have a gene, let's say, that puts you at risk, it doesn't guarantee that you're going to get it. So it's not a fully penetrant, disease that we see, like, for example, in Huntington's disease, if you carry this type of gene with this many repeats, there's a very high likelihood by age 40 you're going to manifest with symptoms. In Parkinson's disease, it's not like that. We don't have a sense that everyone with a certain type of gene is for sure going to get it. So the genes contribute, but then there's certainly environmental factors too. And right now, the types of things that we're talking about are things in the pesticides sort of universe. There's been some pesticides and chemicals that have been outlawed in other countries that we continue to use in this country. And in fact, some of the models of showing what Parkinson's can look like in animals is from using these sort of pesticides and applying them to the brains of animals and stuff. So these are pretty standard ways to cause Parkinson's in models. And so we do use some of these in our environment. I work at the VA. Agent Orange has been something that's been something that we call, it's a service-connected disease with Parkinson's. So if you were exposed to Agent Orange, if you're a veteran or you know veterans who have Parkinson's, you can have them look into their possible service connection if they were a Vietnam era vet, and they can do that through looking on the website, and there's some numbers to call. Camp Lejeune is another place where people were exposed to certain types of contaminants. Trichloroethylene, which is found in like dry cleaning solutions and things like that, seems to be another thing that puts people at risk. So there has been a push to care about this, and we as a Parkinson's community are trying to help others to get rid of these sort of things that have been outlawed in other countries. So a man named Ray Dorsey, Dr. Ray Dorsey is a colleague of mine, and he's been doing a lot of public campaigning. There's what we call it the Ending Parkinson's Disease campaign. They wrote a book, and that book is actually at the end of my slide deck, Ending Parkinson's Disease. That does talk about some of these issues that we've brought up, including the environmental contributors. And there have been some campaigns trying to get more funding, more attention, and they just passed some bill called the Ending Parkinson's Disease or something bill in Congress. What that means for any one of us who's involved in this space is unclear. Right now, they've said that they will have people look more into this topic, but it doesn't necessarily come with money. So, they can have as many people doing stuff for free, but unless it comes with money, we're really not going to get anywhere. So they really need to be allotting, monies to this. Give me 1 second. I'm just going to answer the second before I forget that question. So I think this is important to, get knowledge. So Ending Parkinson's is a good place to get some knowledge. They've come up with a few movies and things like that that are all kind of, if you look up, if you Google Ending Parkinson's disease, some of these things are linked from Dr. Ray Dorsey, and there's some very good folks looking into this. But certainly, I think we all have to push to care about our environments and try to get rid of these chemicals from the environment and from being used currently. The second question was about the registry. Right. So the registry, we have one in California. The problem with registries that just automatically dump stuff from an electronic health record is that one of the issues that we've had is that we don't put in the date of diagnosis necessarily. So what the electronic health record is going to think is that the day that I saw a patient and entered that as a diagnosis is the day that they got diagnosed. which doesn't really make sense, right? Because some people come to me 20 years after they got diagnosed for a deep brain surgery consultation, let's say, and I enter that diagnosis in the chart, and that's what the registry is saying is when that guy got diagnosed. So we have to have better ways to share this information. I think in theory it's a good idea, but the practicalities of how to actually take information out of there and use it with all the HIPAA compliance and all these things is very layered. And I think, we're only as good as how good that information is. And another thing that came out where they gave us the sort of, they put it sort of in the law to do this, but they came with no funding at all. So how to then, so most people found ways in a big place like Kaiser or UCLA, where we were able to just take it from the electronic health record. But you can imagine the individual doctor in the community that just has, an office with patients coming through is a lot of work to add to, whoever is in their, admin or the doctor to have to input this in the website for every patient, So I think when these ideas come about, we really have to lobby for money and, people to help us, actually get this work done properly so that we can then take, answer the question, does somebody who has this exposure, do they have an earlier age of onset or did they live longer or whatever? If that date of onset is completely wrong by whatever number of years, it's not very useful at the end of the day. So,
Do you feel there are any states that might have are doing this?
doing it better?
Yes.
I haven't heard that, but I mean, I think, good luck to you guys. I mean, but this is a smaller state with less doctors, so maybe if they could, if you only have 5 Parkinson's docs in the state, maybe as a model to sort of put people in each of those offices to do this right, or to survey, what would make sense is to find the name from, a doctor's office, but then have a person who's paid to really call and make a 10-minute, thing where they themselves fill out the survey on behalf of the patient with real information would be helpful. But we haven't, right now that's not the case in California, I'm not going to lie. So somebody here had a question. Yep.
I don't know if you can answer this, but when I was first diagnosed, I talked to somebody from the Indiana Parkinson's Association, and she had said that I did the PD generation test. I do have the gene, one of the genes. And she had said that trauma, stress, anesthesia can turn on Parkinson's. I mean, is that?
So I think that, I'm very much about what we call the biopsychosocial model. And if you see my lecture, it makes sense, right? That I totally believe that, the biology of what you have, so the cells that are not functioning well is important. But there's also a psycho and social model. So the psychology of what's going on, your mental health, the stress levels, things like that. And then the social support, right? Social, like you are not a person that is without everybody around you with support, like living in a household with these people or those people or whatever. So each of these things in my mind is a huge factor. Historically, what we've really reduced this disease to is cells that are degenerating with this type of protein that deposits. And that doesn't make sense for any model of anything. It's not just that we have cells that are degenerating. All of these things can factor in. So my thought is, and we have some of the first research in loneliness in Parkinson's, for example. I also have, as I mentioned, a background in integrative medicine, so I know about other disease states. So for example, people get heart attacks. They are at a much higher risk of getting a heart attack because of loneliness, one. But also, if you have lifestyle factors that are poor, you smoke, you eat bad food, things like that, you don't exercise. We know that causes, a sort of an infrastructure to cause you to have more heart attacks. We also know in that space and in many other disease states that if you had early childhood adverse events, so let's say you grew up in a house where, your dad was in jail, or your mom was an alcoholic, or whatever, or you were somehow abused as a child. All of those things, there's a 10 questionnaire, 10 questions. If you get a score more than X, for almost many diseases, we have data showing what your risk of getting a heart attack is, what your risk of getting, cancer is from that data set. We know that from following people who've done these studies answered that question and followed them 30 years. We don't have that data in Parkinson's at all. So I think that, we should care about trauma from even early childhood, but even trauma, so I take care of veterans. So post-traumatic stress disorder, right? Traumatic brain injury. There are many things that we are going through, and many of our veterans are going through on a regular basis that can upset the apple cart in some ways. We all have sort of a way of balancing things, and if some stressor, be it a surgery, be it bad news, your mom died, I don't know, your dog died, you lived through COVID. All of these things can kind of put your balance out of place, and people can then feel like they are starting to manifest the symptoms. With Parkinson's, many of the brain changes that happen when we cut the brains of Parkinson's patients have happened for sometimes 20 years before they ever got the motor manifestations of Parkinson's. So many people we can actually tell are at risk for Parkinson's because of their sense of smell. The mood changes can sometimes happen 10 years before. The sleep breakdown, so people fight in their dreams, they can act out their dreams. Sometimes that happens 10 or 20 years before getting Parkinson's. Constipation can predate the motor symptoms of Parkinson's. So there's a sort of prodromal cascade, what we think is sort of things that make us feel like a person's gonna get Parkinson's, from sleep studies, from smell tests, from these genetic tests and things like that. When that actual motor symptom manifests, it's hard to predict. And so I live in California, the earthquake, Northridge earthquake. If you ask 100 patients living in Los Angeles when they got their Parkinson's symptoms, 10 of them will tell you it started on the day after the Northridge earthquake. Like, it's pretty profound, some of these things that are stressors and that they, feel like things happen since then. Do I think that stress causes Parkinson's? I don't think we have the data on that, but can it uncover, unmask? Is it something that can contribute to something manifesting earlier? I definitely think that that's the case. And then, so what can we do about some past stress? Well, we may not be able to really change what you might have gone through 5 years ago. However, what we can do is try to help you live better now, help you build resilience, help you build some of this sort of stuff with the mind-body approaches. Like I said, meditation, yoga, breath work, all these things are helpful. But also trying to minimize stress if you can in your daily life, focusing on things that you have control over, trying to surround yourself by positive things, by positive people, things like that. So I think, I don't want to, my papers are largely not just about doom and gloom, like these 10 things happen, we exposed you to this chemical and, then we covered it up, which is what Lejeune is, or other things. I really want to focus really on, in my sort of space on, then what can we do about it today? How can we live better and prevent this from happening to other people down the road too? Does that make sense? Okay, perfect. Any other questions? Yep, sir.
My wife and I are reading a book now titled Parkinson's Democracy.
Okay. Who's that by? I don't think I've heard of that one. Okay.
He has Parkinson, and he served as a lawyer on brain trauma cases out of San Francisco. And he writes that there's a three-legged approach to fighting Parkinson's: medication, diet, and exercise. It seems I think we all can agree upon a good strategy. Are you familiar with any studies showing that intense exercising that raises the heartbeat quite a bit for a period of time, that type of exercise can actually either create or protect dopamine?
So I think that, the data on that it's a bit confusing, to be honest. And they've done a number of studies looking at what is the optimal exercise paradigm for a Parkinson's patient. And it's very, and as the pendulum swings, like today, protein is like the greatest thing you can eat. And like 20 years from now, it'll be like, no, we should all be eating fat. Like this is like these paradigms keep switching, right? And just like that kind of stuff, I think the Parkinson's paradigms have switched a lot. I think what is true is that the best exercise to do is the exercise that you will do. So it doesn't make sense for us to all, and what my problem with a lot of these paradigms and how we study things is that we sort of, classically take a pill and we randomize it against placebo, and then we have a bunch of blinded raters say this is this, right? and say this pill worked better than placebo by this much and that's what the effect is. How do you do that with something like exercise or diet or social connection, right? These things that are a little harder to put in a box and to package. So I think, you know, my sense, having taken care of Parkinson's patients for over 20 years, is that people have a secret sauce. And there are people that I can meet on day one of Parkinson's and their twin brother. And I can tell you which one's going to do better just by, you know, some things that I just get a sense of. And I'm trying to understand how to kind of put that in a book, actually. And I think some of that is that the person feels in control. Some of that is that they do things in their lifestyle that really build, you know, something that is sustainable, right? Because it doesn't help to sort of, and I think there is a sense that if you overdo things in some patients, that then they spend, you know, one day killing themselves at the gym, and the next 6 days are spent in recovery, and then they like finally have the energy to go back, or they never want to go back again, right? So that's not a great sort of health paradigm. And physical therapy, I think, is amazing. You know, personal trainers are amazing. But to get this stuff to like the common person who doesn't have access in many parts of the world, we don't even have access to levodopa, believe it or not. Cinemed is not available in so many countries in Africa. It is heartbreaking. I can't even prescribe that to people because they can't get it in their country. So how can we help people live better who have not just no access to amazing therapies like DBS and all these whatever new things that are coming out, but just even basic medicines that have been in the West for 50 years. So I do think that things like valuing exercise, whatever that may mean to you. So getting your heart rate up. So Bas Blom, who's an expert, he's been doing this for a long time, works with a lot of physical therapists, will say, you know, 30 minutes a day of getting your heart rate up enough so that you can be somewhat panting. But it doesn't have to be that you're drenched in sweat and that you're like going crazy. Because sometimes, you know, severe exercise is actually traumatic to the body and the aging body, especially of women, for example, with bones and, you know, joints that are a little bit sort of. So I think I think things like yoga, which you have some meditative aspects, you have some stretching, you have the breath work that comes along with it, which helps the autonomic nervous system. You have your own resistance training, you have your own balance training. Those are very helpful. Using weights a little bit to build muscle. Walking is free. You know, do it with a friend. Maybe get your heart rate up a little bit so it's a little hard to like fully speak well. It shouldn't be so slow that you're, you know, able to comfortably have a full-on conversation. Maybe get your heart rate up a little bit. These sorts of things are helpful. But I don't think that you have to be crazy like a marathon runner or go nuts. And I don't like the concept of making it so exclusive that you have to drive to Indianapolis or Chicago to get on somebody's, you know, bougie bike in this guy's gym and go up to 80% heart rate, because that's not accessible to anyone but his patients, right? And even his patients aren't going to want to pay the $20 parking to get in that place, you know, after the study's done. So then we have to make it accessible so that you want to do it. But there's other ways to get your heart rate up too. I mean, dancing, you know, if you like it, or hiking in nature if you like it. Whatever you're going to love to do that you look forward to is really what I'd like to get people doing. And if you can do it in a group, you've like gotten 2 sort of brownie points there. So, any other questions? Yes, ma'am.
I have had a cough.
You've had a cough?
For about 3 months.
Uh-huh.
And I can't shake it. I mean, is that a Parkinson's thing, or is that something else?
Yeah. If it's a continuous cough when you aren't eating or drinking, it's not classic for Parkinson's. I mean, there's a lot of bugs going around right now, some various viruses, even like the after effects of COVID sometimes can keep having, if it's associated with shortness of breath and other things, I would definitely probably check in with your primary care doctor, because it's not classic for Parkinson's. But we do worry about coughing in Parkinson's when it's associated with things like if you lie flat, you know, and your secretions go into your throat, or if you drink fluids, you know, liquids, and you start coughing, it may be that the sort of protective apparatus that protects your fluids or food from going into your lungs is not working well. And so we need to take a look at that. The safest way to help your pills work the best for mealtime is to try to space your pills an hour before eating or drinking, so that your Cinemet, for example, is working well when you go to eat and drink. So I always try to give it like when you wake up and then wait an hour to eat your breakfast. When you take your lunch, try to do it an hour before your lunch and an hour before dinner so that your pills are working well. The other reason that that's good is because protein in your meals can affect how the Sinemet is absorbed, and then it doesn't work well if it's taken with protein. So protein drinks, milk, cheeses, meats, things like that, don't let the Sinemet absorb. It's actually can make it just stay in the belly and not absorb well. Sure. Yep.
On that same topic there, does with protein
Mm-hmm.
especially, is it still okay to take the pills with the 1 hour gaps? For example, with a protein drink?
Yeah, yeah. So there's been a lot of talk about minimizing protein, and Rochelle's ears are going to be burning from this talk because I mentioned her name like 3 times. So I'll have to tell her why after. I'll send her a text. But she and I and another dietitian wrote a paper on protein restriction. And I think the bottom line was that we don't think that people should restrict protein just to time it away. And really, if you do feel like you're protein sensitive, so what you can do, sometimes when people start to have these fluctuations, so they feel like their pills aren't working so predictably as the disease sort of changes and progresses, sometimes we need to adjust the pills. But sometimes these lifestyle things, like when you're eating, how much you're hydrating, things like that can make a difference. So there is a thing called a motor diary you can download. It's actually on our Padrick website. And basically what it is it breaks down the symptoms like by 30-minute increments. So you're either on with dyskinesia, off where your symptoms, where your when tremor, stiffness, slowness coming back, or sleep. And you fill out this thing and you like shade it in or whatever for every 30-minute increment for the 24-hour cycle. And you can bring it into the doctor and show them actually visually kind of what your symptoms are doing, and you circle when you took the pills. So it's kind of a nice way to track your symptoms, and then if you make a change, you can then sort of do the same after you've made a change. And if you're noticing that after you've had certain proteins or whatever, that you tend to have more unpredictability in the day, even with the spacing, sometimes we can just eat more protein towards the end of the day because you're going to go to sleep anyway. So, but I don't like to cut out the protein, especially in people who are aging, women. The muscle mass and frailty is a big deal, and sometimes, we also, I'll take your question in 1 second. These sort of weight loss drugs and stuff that I see on every billboard as I'm driving from here to there. Those are dangerous actually in our patient population because, as I mentioned, weight loss is not a good thing in our patients, and so you want to be really keeping on some level of muscle and some amount of weight. Not that we want to be too heavy, but I think being in a good range and not trying to under nourish and lose weight unnecessarily, because once women especially start losing weight, they can get into a cycle where they can't put it back on. We have to gets very scary actually if we start to lose too much weight with those dyskinesias and things like that. So I think there's a lady there, and then I'll come back. Yep.
Connected to what you
Okay.
proteins. I just read something recently that kind of struck me. It was about protein drinks.
Uh-huh.
And the amount of protein that's in some of these drinks that your body can't really process
Yeah.
that quickly. And
Yeah.
you're just gonna, it's just a waste.
It makes your urine expensive, yeah. Well, I mean, I think, we're talking about things like these bodybuilders, right? And like, I know my kids are always like, now, oh, Mom, it doesn't have any protein. That's a waste of food. I'm like, okay, well, I think, again, and I've been around long enough, and I'm old enough to have seen, I remember when this was like a fad 20-something years ago, and then it was like, oh no, the average American diet has way too much protein already, and then now we're back. So I don't know what the word on the street with the gym people are, but I think for Parkinson's patients, things like Ensure, things like that and if you have a sugar intolerance, things like Glucerna are reasonable. I would definitely talk to your regular doctor or the Parkinson's doctor. You can get a dietitian as well to take a look, part of the multidisciplinary team. And if they don't know about Parkinson's, they can go on, Parkinson Foundation and stuff has some resources. we're pushing to have dietitians specifically learn about Parkinson's disease so they have a better knowledge about that, because some things that they would tell some patients may not apply to our patients. So I think generally, I think lots of fresh fruits and vegetables because we get constipated, with Parkinson's. Also, hydration is so key. Like probably at least 40 ounces of water. I see a lot of people with their bottles of water. Good job. And it's hot, right? So you want more when it's hot. So try to keep hydrated. And that means generally free water or Gatorade, not things like with caffeine, or juices can make you pee too. So or sweet teas, all these teas that I see, the blue drinks over, I don't know, I think there's Kool-Aid out there today, I saw that. But we don't get all these things in California, but I would just stick to water or sparkling water or Gatorade if you need the electrolytes. If you tend to have low blood pressure too, things that are salty, so things like V8s, tomato juices, things like that, or some of the water, like vitamin water, something has some more electrolytes in it. So things that are electrolyte dense, not coffee, tea, juices, all don't count.
They have that coconut.
Coconut water is good. Yeah, coconut water is good. It has good electrolytes. Did we answer your question? I think so. Okay, go ahead.
Last question, please. I'm pretty new to this. You've used the word several times, dyskinesia.
Yeah, so the Michael J. Fox kind of movements, like the writhing movements that Michael J. Fox has.
Okay.
Yeah. Yeah.
What's the last app you mentioned?
What is it?
The last app you mentioned?
My Moves Matter.
Okay, thank
Yeah, that's for shows. So,
No, the last one.
My moves matter.
No, I've got that.
The one, the log, the diary.
the Pro PD?
No.
Oh, the Motor Diary. That's not an app. That's not an app. That's you actually download that from the PADREC website. PADRECC. That's the Centers of Excellence in the VA. So, all right. Well, you guys have been just an amazing audience. I really love the love of all of you too. Hopefully, I'll take your question 1 second. I hope you guys can connect with each other because that's actually really where the magic happens, and support each other and get to know each other. So, homework for you guys today is to plan another event with the ladies maybe in the next month, okay? That's your homework. I literally write this stuff down now, and people who read my after visits are like, what is this stuff that you write on here? It's very odd. I'm like, don't carry around so much crap on your back. Like, I write this stuff down, and like, this is a very odd sort of way to counsel your patients, but I literally write it in my after visit summary. So, ma'am, you had a question there?
I think it's a final question.
Okay, sure.
When do you sleep?
When do I sleep? I like to sleep, actually. I have my 15-year-old over there, he can attest that. Sleep's really important. I mean, I think, a lot of what I do is on the fringe. So I tend to be someone who's pushing the envelope to really try to catch up, honestly, to where cardiologists and oncologists and everybody else in medicine has been. So we really just need to do this together. But I definitely enjoy coming out and hearing from you guys as well. It's so important for my work. I appreciate that, and I, get involved and advocate for each other. It's a really important thing to do because we can't change things unless we all sort of, pitch in, right? So, okay, thanks for the time.
Thank you very much. And this is a gift from us.
Oh, that's so sweet. I love it. That's so beautiful. Thank you.
So hi, my name is Roberta Wong. I've actually been a professional dancer, 15 years, dance for Parkinson's teacher since 2011, so 20 years. Other teacher, ballet dance, modern dance as well, 30 years. All right, what's happening is I have so much information as well that I'm still processing what she was saying while I'm trying to do this. Okay. In a nutshell, this is a wonderful strategy for you guys to use that is a complementary, non-medical, non-therapeutic, but completely enjoyable from the feedback that I've heard for all of your, say, exercise, movement regimes, etc. I'm just going to describe it really quick. And I have flyers for you guys over here, and I will send links. I've sent a few to Sherry, and I want to thank you for having me do this. So, okay, danceforparkinsons.org. That's your source. www.danceforparkinsons.org. What you'll find on that website is also that this has been going on since 2001. The creation of this program came from a support group leader named Ole Westheimer, who was doing a support group in Brooklyn for Parkinson's, people with Parkinson's. And thanks to her, she decided my support group people need movement. She goes, Mark Morris, internationally renowned choreographer, and his company are right here in Brooklyn. They partnered up, they co-designed the program, they did a lot of research, they did a lot of experiential and on-the-ground research, they got a lot of feedback, and the program has now not only survived, it has thrived since 2001. It is now in 300 centers and 28 countries. It's a completely international program. Once you get on the mailing list, they actually have a festival. A festival about once every year. And you can, since you might be up in the middle of the night, like some of us are, you can attend, say, a class from South Africa. You can attend a class from Australia. You have friends who are over in England. You have friends in Tennessee. Like, people are presenting this all over the world, and it's just quite vast. Which brings me to the next point. I think one reason it hasn't caught ground here, there are actually 3 existing. I helped start the one in Bloomington, which is still going on. Wheezy Smith was the founding force. She had Parkinson's, and she really needed the program, wanted it. I helped co-start the Dance for Parkinson's in Indianapolis. That one did go under because we were housed at the senior center on Michigan, and they closed the senior center. So we have recently started, there's one in Fort Wayne with Liz Monier, and Dance for Parkinson's at Indianapolis Ballet is what I represent today. So that started 2 years ago. Agnes has been one of our actual, and Joan, participants since the beginning. And if you are, still concerned after seeing this and trying the demo, please talk to them. They can fill you in more about what it is. I'm also going to, at John's suggestion, send you the link to the WRTV6. Rafael Sanchez did a piece on us, which was very well received. And it'll show you exactly what goes on in the studio. It'll show you what kind of things that we do. So part of it, I believe, is dance is just too unfamiliar for some people. One of our participants who came back several times, Rick, who takes it rock steady, he goes, he said he loved it, but he goes, I have no idea how to describe this to everybody else at Rocksteady, right? So there's reasons for that, which I'll get into, but just to let you know what it is, a little bit more. And I also am going to offer you the option. I think we're going to start standing since everybody kind of came in, and I don't see a lot of, assistive devices, right? But we'll stay for a moment, and just I'll go through part of my spiel. Literally, again, part of this talk was going to be how to have a mind of a dancer and why, and how this applies to people with living with Parkinson's. I'll go to the end outcome of that already. A lot of the feedback that we've received from all of those programs is I come out brighter, I feel more at ease, I completely forgot I had tremors all morning, and all of a sudden it was gone because I was concentrating on these exercises. I feel a better balance. Part of it that is different is we use imagination. Part of it that is different is you were so completely somatically in touch with your breathing and your moving. Or part of it is in the mind of a dancer. You just don't think. You follow, you listen to the music, it's beautiful, and you just do the task. And all of a sudden you're like, oh, that's nice. Totally forgot everything else. So, anything else that I wanted to say? There's also Sing for PD, there's Dance by Phone. So if you're having issues visually, you can still call it up, and you can actually do exercises they describe on the phone. All the teachers are trained, yeah. Most of us have a long reputation for dance. So you're getting someone who's experienced as a dance teacher already as well. I've had the pleasure of actually teaching now in also 5 senior homes. So really have an experience on the range of all this. The mindset that I summarized is from this morning, meditating on it, is every day it's just a new you. So that's the approach. You get up every single day as a professional dancer or as a person who is thinking like a dancer, and you just approach, okay, what's going to go on today? How is the body feeling? What did I do yesterday that's causing this? All of those reflections, yeah? But it makes you very aware of your actions and your intentions, yeah? As well as also your joys, yeah? You can talk to 10-year-olds who've studied, for 7 years, and they're just like so many trials and tribulations. But the perseverance and the discipline and the repetition has what has also been learned. And those are huge, huge things. I'm just going to go down a few of these. So, mind of a dancer, no expectations, just curiosity. Yeah, for whatever you're about to approach. You try and practice observation without judgment. Huge, right? Determination, discipline, and persistence, but also the willingness to let go, right? And these are all practices. These take a while, but they also apply very quickly. Patience, encouragement, curiosity, creative solutions, courage to change, and courage to let go. Yeah? I'm thinking of one of our most recent students who came back 3 times, but was not in the headspace or the physical space for himself to shift his mind a little bit about what the class was. Yeah. He was very strict with himself. He was a professional symphony musician. He had moved back to Indiana to caregive for his mom. And then, of course, from the stress of that, perhaps released. And then he got diagnosed. He said he was still practicing his violin 3 hours a day. He was very regimented on his schedule. And I said, I can try to give you some private lessons. Let's see how this goes. And he said yes, and then it just was, he couldn't. I said, you know what? If you have too much going on, just relax and let some of that go. So, wishing him well. Find relationships with your environment. A lot of the awareness is not just a self-awareness, but you have to understand what is in your environment and how to work with it. And let go of things like, okay, I can't remember which is right and left or something. Okay, there's a window side and a clock side. Great. I got to walk this way. I got to go this way. Go to the window. Go to the, Look, I can kind of see it without my glasses. I did it in bold. Okay. Make everyday activities into a dance. We've had a lot of good feedback from some people about just finding rhythms, right? When you're getting stuck, when you're getting a freeze, when you get something that you start to either sing to yourself, or you start to feel the rocking that we sometimes practice in class until the body starts to go, or you completely just not worry about the action you're doing and you think about something else and you automatically don't get in your way. Just think joy. Sometimes it's simple. Just do. And then all of these just increase the tools in your somatic toolkit. We talk about movement vocabulary being increased. We talk about neurons that fire together, wire together, which is the latest neuroscience on that. And there's also dance and neuroscience majors starting to emerge now, which is so cool. The other side of it, though, is why to think like a dancer. Because a dancer's life is short. And once we pass through it, we must embrace a new reality and the passing of the old one the former body and the former identity. And I'm getting teared up because I have been working a lot with people who are now in, say, golden years or, differences from what the youth was. There's a wonderful article that was done by Wendy Whalen, for Wendy Whalen, who was a New York City ballet dancer principal, who kept coming back after injury. And supposedly the quote actually in the article is from Martha Graham, who's one of our pioneers of modern dance. Yeah. Martha Graham was the first dancer ever to receive the Presidential Medal of Freedom, which is the highest citizen honor for the US. It's like the Rose de Chevalier in France or something. The quote is, "A dancer dies twice. The first when we retire," right? And they said the first is always the hardest. So, I encourage you to keep moving forward. Sorry, I can feel like she said, the love in this room is lovely. I encourage you to choose joy, and I will leave you speaking-wise with a well-quoted passage and misquoted from Martha Graham. "There is a vitality, a life force, a quickening that is translated through you into action. And because there is only one you of all time, this expression is unique. And if you block it, it will never exist through any other medium and be lost." So I encourage you to keep moving, to choose joy, and to find who you are at this very moment. So let's go ahead. If I have 20 minutes, 15? Okay. We're going to start with a creative moment after all. So remain just for a moment, and you can wiggle your legs out if you need to, and also make sure you have a little bit of room. So part of the balance you can practice, no matter if you're standing or not. I love it. Everybody's like, I need space. Awesome. Yeah, just spread out. Dancers, just spread out. You can be anywhere in the room. Okay, so the first exercise is one of the hallmarks of the program, and it's about imagination. And I had a big sign just to cue you because I like to use visual signs in case people can't hear me. But we're going to pick flowers for about 2 minutes. So the idea of picking flowers, it just started without me and I don't know what's playing. Oh, it's a phone. Okay, sorry. That's great. Okay. The idea is sometimes trying to pick up movement or trying to do your physical therapy exercises or trying to do, those directed, structured things actually can block you sometimes. So what we sometimes start out with is an imagination exercise that can be your own invention, and it's very familiar. I tend to cue a little bit just so you know what we're looking at. So we're going to go to your garden. You're going to see your garden. You're going to see if the sun's shine or if it's raining. You're going to feel the air wafting around you. You're going to see the flowers you want to pick. You're going to take your basket, and it's probably huge. And you're going to take, you've got a glove on, and maybe just pick some of those flowers and put them in the basket. Maybe you can stop and smell them. Yeah. Maybe there's some weeding you want to do as well. You'll come back to. Perhaps you want to go ahead and make a bouquet. So, you have to clip the bottoms and let them fall off, and then you have maybe your string, and you're going to tie it up, etc. We'll just do this for like 1.5 minutes, but you'll get an idea. Can you see okay? You can scooch around, okay? Our music today is Souvenirs by Stephen Goodhines. Part of the hallmark of the program is using music that is just so joyous. So maybe you see the sun, and it's got some sun rays, and maybe they're on you. Maybe there's a cloud going by. Keep going. I'm going to turn it up just a bit. Oh, look, maybe there's some birds. And you're out in your garden, and it's gorgeous, and it's vibrant, and it's very alive. Let's pick some flowers wherever you want to go. Was that a rose? Ooh, there's some dandelions. I don't want those in my garden. Okay. Oh, there's a branch. Let's see if I can get that one off. Do you have tulips? They need cutting, right? So you don't cut the bulbs. Maybe a couple of wildflowers just to get the mix going. And maybe take that tape, that floral tape. Exactly, and it gets tinier and tinier and tinier when you wind it. What a beautiful, beautiful bouquet. So I want you to see somebody in the room, and I want you to give them your bouquet. And somebody gave you one as well, so you can smell that too and enjoy it. Maybe the petals feel soft. And put it somewhere in your vase. All right. So believe it or not, these can develop into all sorts of layers. Yeah. And I encourage you, even if you don't want to come to dance class, just do this at home. Just put on some fun music. All right. We're going to take part of the warm-up. The warm-up is a signature thing to start with. But it's the idea, you're going to be on top of your sits bones. This is the practice balance thing, even if you're not standing. Yeah, I guess we're going to start seated, or you can stand if you want, but we're going to be reaching. So the balance of it is your sits bones, your ischial tuberosities, I was a biological science major, are underneath your pelvis, and your pelvis feels heavy, or it feels vertical if you're standing. You're going to reach it up. You're going to press towards your heart. You're going to reach it up and release. Again, scoop and reach, feel the pressure through, and release. Today you're going to take your shoulder and reach out, and your shoulder reach out. You're going to make a heart, and release it. And we'll do that a couple times just to get you moving. Now that I have shown it seated, I'm going to start doing it standing for those who want to stand up. Here we go. Dear Evan Hansen, here we go, reach. Release. Expanding yourself in your space. Feel the air support you. In to the in. Make a heart. Again, to the in. And the end. Beautiful, everyone. Make a heart. Let's go to the side and reach. That's it. Feel the air you're pushing against. Feel yourself gathering. And yes, you can totally yawn and stretch. Across a one, a two, two, a two. Heart. Release. Last time. A one, to the reach. Two, to the reach. Beautiful, everyone. Fabulous. All right, shake them out. So then you stop and notice, hopefully you're feeling a little bit like more at ease or a little brighter or something. Let's keep going on. So this one will be standing if you want to do the standing. And again, I'm just shortcutting all of these a little bit. The whole class takes an hour. We take our time longer, warm up. We do some other things as well. I'm going to take 2 hands or 1 hand. I'm going to be unassisted. And also we are on Zoom, so please take a flyer and get the information for that. It seems to be a popular option. We're going to start with something called a plie. To get to the plie, your feet are in a V, Pilates V perhaps. It's first position. Exactly. She's already doing it. You want your tail feathers down. You want your tummy in strong. You want to relax your shoulders and your neck so you have freedom on the top. You want to go straight up and down, and you just bend your knees. That's it. We'll take 3 times on that. It'll be nice and slow. Just breathing, feeling your own pulse. Then we tendu side, make it a little wider. Again, plie 2. If you want a balance challenge, you can have a hand here, or if out. Some of my people like to have out as well. Sometimes it's a better balance, yeah. And we're going to close. We're going to take something called a releve. You're going to push the floor away and rise, and then release. So my heels are gently rising off the floor. Release, that's it. Rise and release. Then 1 tendu and go. Last time you're going to push the floor away. That's it. And 2. And 3. And then we'll close. So just that little bit of balancing as we go, yeah? If you need to start or want to start a little wider, that's fine. Or if you want to start parallel. And typically we have a class assistant, so the assistant is going to do the other as well, so you can follow either way. Here we go. Hamilton. Plie means to bend, soften, stretch. A 2. A 3. Easy tendu side, make it a little wider. Exactly. Plie 2, that's it. Very nice. A 2. Just softening. That's it. Releves, push the floor. Push and up. Push and up. And change. Last one, and push. Yeah, squeeze your bum if you want a little extra back there. And push. Good. And center. Very nice. All right. Good. So our last one, I think, second to last. Go ahead and have a seat. Part of what we do is imagination, but part of it is also structure. A lot of people like the sense of structure. Sense of structure makes you feel a little safer with your movements. It also gives you this movement vocabulary that you haven't had before, perhaps. This is a ballet port de bras, as I am ballet-based, and I love ballet. You're on your sits bones, your shoulders are stacked over your hips, your spine is free and spacious. We're going to start wide. You're going to close to first, 2, and second. 1 arm to third. Take it up to 4th. High 5th. Low 5th. Allongé. Yeah? Yeah, get where you can see me on this and make sure you have some room. Okay. And the fun thing about doing the Zoom class, like if you need to stop, if you need to take a drink of water, we had somebody who started eating breakfast sometimes because that ended up being his breakfast time. It's all cool. So here we go. Phantom of the Opera. Ready. To the first, hold 2. To the second, nice and wide. Third, reach. 4th and stay. High 5th and stay. Low 5th and stay. And now I'm going to give you a narration for the second half. So you're going to hug your grandchild. And of course, they're going to run away. But they're going to come back and give you a balloon. And the balloon's going to rise to the sky. Catch that balloon. Bring it down. You're going to release it because they're back here. Take your balloon. And now we're going to do something double time, twice as fast. 1, 2, a 2, a 3, 4, high 5th, low 5th, fabulous, release. Other side in 1. First position, 2nd, 3rd. And now watch out for the glasses of water and all that. Release. Fantastic. All right, good. Okay. So again, this is like more than Reader's Digest. This is just, tiny little bits, yeah. So you would work on some structure, you'd work on some things also knowing that they're legitimate dance steps. So it's kind of like studying a language in its own way, right? Okay. So then our last thing is we're going to do a tiny little dance in a tiny amount of time. Okay. You can stay seated for this, but I'm going to go ahead and stand because it's easier for you to see me. If you need the safety for the balance, just use one hand on it. Otherwise, we're 2. I'm going to stay hip-width apart, and I'm going to pretty much track my toes forward so that this is a stable grounding place. We have noticed, though, if you want to slightly turn out, some people feel more stable being that wide. Yeah, so your choice. Whatever your natural affinity is for that. You do want your sits bones underneath you, nice and tall. The first part of the dance, you're wearing red, white, and blue. You're on a Broadway stage. There's like 16 people next to you. And it's just a very fun number. So you're going to start going, 1, 2, 3, 4. You're going to cross and up and across and up again. 1, 2, 3, to the shoulders, up 2, and up 2. That's the first part. We're just going to practice that really quick. Will Rogers Follies, and 1, 2, 3, 4, cross 5, 6, 7, again, and 1, 2, 3, shoulders, and 5, 2, 6, and 7. That's it. Good. So then the last thing you're going to do is you're going to do 1 and 2 to the blank, 2 and 2 blank. I'll explain more in a minute. There's a mystery here. And you're going to go cross to your shoulders. You have a jingle hat on. You're going to throw it off. Okay. So ideally, strangely enough, this number has all the people seated. And you have right next to you is another person. And I'm going 1 and 2, and I'm going to hit their knee. So if you want to try it next to somebody, you can. Hopefully you know them. But we will start at the top. And this will be our last thing, but just enough to get you moving so that you can, go out the door happy, right? Okay. So again, review. 1, 2, 3, 4, cross 5, 2, 6, and 7, and 8, again, 1, 2, 3. Don't worry if there's little mistakes, 5, 2, 6, and 7, it's okay. 1, long you're having a good time, 3, 4, 5, 2, 6, 2, 7, and 8. Cross, cross, hat, and hold, and toss. All right. So this is your mini lesson already. We're doing a dance. Good job, everyone. From the top, please. A little louder. Ready? Here we go. 1, 2, 3, 4. Cross a 5, 6, and 7. And 1, 2, 3. Shoulders, 5, 2, 6. And we're smiling because you're on Broadway. 1, 2, and 3. Other hand, and a 5, 6, and 7, and 8. Cross, 2, cross, 2. Hat, toss. Fabulous. Okay. So then the very last thing we do is we have something called pass the pulse or pass the gift. For me, I modify this sometimes, or it's different in other classes, but I'm going to ask you to look at least 3 people and say thank you for dancing with me today. So go ahead and find 3 people to say thank you for dancing with me today.
Thank you for dancing with me.
Thank you. And then to everyone, guys, thank you so much, and thank you for, I hope you liked a little bit of what you saw. Remember, this is just another supplement, but please try to put it into your regime. We're finding it has a nice balance to, say, the rock steady or other things you're doing as well. So we invite you to come join our community. Thank you.